say welcome to everyone. And as you sign in, thanks so much for attending our event today, to our event, which is called Tobacco and Nicotine Cessation, Why It Matters and What You Can Do. My name is Sharon Elaranta. I am the medical director here at the Washington Health Alliance. And the Alliance is very happy to partner with the Washington State Department of Health to bring you this session today. Over the next 50 or so minutes, we're going to hear from subject matter experts, starting with a look at the harms that are both physical and economic harms. Then we'll have a chance to dive into how we can help people stop using tobacco. What are the modalities that are available? How do they work? Which are most effective, and so forth. And I want to go back a little bit for both the harms and the modalities, everything, to remember that we are viewing everything here also through an equity lens, because what works for some people doesn't work for everyone, and the harms aren't equally distributed either. So we're going to be keeping that in mind. Following a discussion of those cessation modalities, I'm going to review the results of a survey that was done of major Washington state insurance coverage of cessation modalities and where there might be some room to improve with regard to the way these modalities are covered by insurance plans. Then we will hear from the Washington Department of Health about their current priorities and strategies for cessation. And as we move forward, I'd like you to kind of keep something in mind, and that is what you can do from your vantage point as a stakeholder. If you're an employer or a union trust, a group that helps to provide health benefits to your members or employees and their dependents, how can you help to improve cessation efforts in Washington State? Same thing for health plans. We'll be talking a little bit about what health plans offer, but is there anything that you can do in terms of thinking?
Got it.
Or barriers that may exist to accessing appropriate cessation modalities? Providers. You may think about what you can do when next you see a person who's interested in tobacco cessation, what you can recommend. And also, of course, patients and allies, what might be your role. And we see ourselves at the Washington Health Alliance as an ally in healthcare. So we hope to have time at the end to review questions and comments. But we're going to keep going and do the webinar, and we'll get to those at the end. We hope we can. Please enter them in the chat rather than in the question and answer area. We will be recording that and making note of it, again, trying to get to them at the end. And if that is not possible for any reason, we will be able to answer folks following the event. Couple little quick things on housekeeping. As you may have noted as you entered, this session is being recorded. So other than speakers, everyone's microphones and cameras are disabled. And again, please use that chat function if you would to enter your questions and comments. And so let's get to our content for today. And it is my pleasure to introduce our first subject matter expert, Dr. Thomas DeCato. He is a clinical assistant professor and respiratory systems director with the Elson S. Floyd College of Medicine at Washington State University. He is also medical director for pulmonary function testing and exercise physiology laboratory in the Division of Respiratory and Critical Care Medicine at Harbor UCLA Medical Center. He is a health sciences assistant clinical professor of medicine at the David Geffen. So are you all seeing? And we are just thrilled to have you here. I will advance your slides, so just let me know and say next slide. And the floor is yours.
Great. Thank you so much for the opportunity to speak. So I am going to talk about the problem, tobacco use, as it relates specifically to Washington State, of course. And this slide, so data from the state, it tends to be a little bit older than some of the data you can find from the American Lung Association. And so adult smoking in 2017 in Washington State was about 13.5% of people. E-cigarettes, a smaller percentage, about 4% of adults. And then youth overall use, so that includes cigarettes, cigars, smokeless tobacco, hookahs included in there, as well as e-cigarettes, was just under 25%, 22.6% of people, and that number is from 2018. And you can see compared to the United States, about average or so at this time, how Washington compares to the rest of the U.S. And this figure on the right side shows state ranking by state. And this is, again, from the American Lung Association and is 2022 numbers that they published. And so the average in the US, the average smoking rate was 14%, the national rate. And Washington State is the orange bar, and they're considered slightly above average at 12% in 2022. And I also want to mention, as already has been mentioned, of health equity, and tobacco use is actually also a health equity issue, and I'll talk about that more as we go through the slides. Next slide, please. And so this slide is meant to depict a little bit of the health equities involved in tobacco use. And so this data, again, comes from Washington State. It's a little bit older, but the most recent that I could find, it comes from 2015 numbers. So you could see at that time in Washington State, the percent smoking was 15. And so there's a red bar there for everyone in Washington State. And you could see, depending on the group of people listed, that some groups smoked less than that average rate in Washington and some more. And there are potentially several things that link specific groups to higher levels of smoking and then ultimately higher levels of smoking associated diseases. And really, this dates back to the 1960s and 70s when companies started to target women specifically, and we're really still seeing the ramifications that today, where the incidence of lung cancer has been decreasing actually of late, but more so in men. In women, it's, I think, finally started to plateau, and now lung cancer rates are starting to decrease for women. But there's other things. There's, of course, this tailored marketing and advertising to specific groups of people, specific flavors, especially flavored tobacco products that are targeted to youth populations. And also there's increased exposure to secondhand smoke in some populations. These tend to be folks who have barriers to healthcare access in general and treatment for tobacco use, folks at lower income levels, lower socioeconomic status, those measures. And so you can see that there is a difference amongst different groups of people. And so these disparities continue to exist today. And we can go to the next slide, please. And here's a little bit just of, again, specific to Washington State, a few statistics that maybe you've heard, maybe we're aware of these things peripherally, but some of them are quite staggering to me, at least, that on average a smoker will die 10 years earlier than a non-smoker. And 20% of deaths are caused by cigarettes, and that does include secondhand smoke exposure. And then this number, depending on the source, you can find various numbers, but a little over a quarter of cancer deaths are caused by smoking, which is quite astounding. And a little over 100,000 youth alive today will die prematurely from smoking in the state of Washington. Next slide, please. And so what I wanted to do now is just talk a little bit about these diseases, the morbidity and mortality associated with tobacco and nicotine use. And the first four listed here are the ones that probably generally people have heard of. So chronic obstructive pulmonary disease, COPD, cancer, and specifically I'll talk a little bit more about lung cancer, and then cardiovascular disease, so meaning heart disease and stroke primarily. And the other one is how smoking affects pregnancy. Preterm delivery and low birth weight are associated with smoking. And I'll talk as we go, a little bit about the ramifications to that, to the child who then becomes an adult but was born preterm or at low birth weight. There's an increased risk of SIDS, sudden infant death syndrome, to babies of mothers who smoke, and an increased risk of postpartum VTE or venous thromboembolism, so deep vein thrombosis or pulmonary embolism in mothers. And then if you, I think, advance one, it'll throw some other things up there. Oh, sorry, it's going to go one by one. So I think there's 4 more. Sorry about that. And there's some other diseases that I think are less well known that are can be caused by smoking. So diabetes is one. Other infectious diseases, so tuberculosis, actually not a huge problem in the United States, depending where you live, though. Influenza and invasive pneumococcal disease, so pneumococcus being one of the most common organisms, bacterial organisms that causes pneumonia in adults. And then even some neurologic disorders and cognitive decline are being linked to smoking. Eye disease, macular degeneration, and cataracts also linked to smoking. So some things that I don't necessarily treat in my regular practice, but are also being linked to smoking. Next slide, please.
Oh, sorry.
Oh, sorry. Yeah, and worse outcomes after surgery. So this is really for any surgery, but smokers are at risk for having complications after their surgery, surgeries. That might mean increased risk of complications, wound healing, things like that. Okay, that's the last one, I promise, on this slide. Thanks. And this depicts this a little bit. So these are many of the things I listed. The ones in red, so this comes from the Surgeon General's report on the health consequences of smoking. And on the left side, you have cancers. And the ones in red are things that have been more recently linked or newly linked as of this report to smoking. And so liver cancer and colorectal cancer being the newer ones. And I'm going to talk more about lung cancers in a little bit. And then chronic diseases. Again, I've mentioned many of these things. The ones in red also more recently or newly linked to smoking. So diabetes, I mentioned, ectopic pregnancy, sexual dysfunction, even rheumatoid arthritis. And then I'll talk a little bit more about immune function as we go. Next slide, please. Oops, sorry, I think one back. Thanks. And so here is the most recent mortality data for Washington State that I could come up with from 2020, and you have the 10 leading causes of death. And so again, 20% of deaths in the state are caused by smoking. So cancers being number 1 on this list at the time, followed by heart disease. So heart disease, I think kind of the first association that people make with smoking is lung disease, COPD, lung cancer, but really a higher proportion of smokers go on to have heart disease and strokes, cerebrovascular disease, number 6 or so on the list there, than COPD. Chronic lower respiratory disease will include COPD there. And so smoking related diseases are obviously well represented here, and 20% of deaths in the state are linked to smoking, probably a higher percentage of cancer deaths, which we'll look at here. But next slide, please. Next, I wanted to just mention, well, why is tobacco use bad? There's more than 2,000, and actually, depending on the source you read, there's maybe up to 7,000 or 8,000 constituents that have been identified in tobacco smoke that are harmful. And they come to affect us in different ways. There's kind of this gaseous phase where there are gases generated that are toxic, and then this particulate phase, or tar phase is the other word, where there are aerosolized particles that get deposited in the lung and are harmful to us. Those typically contain reactive oxygen species, which cause cell injury. But overall, there's this direct irritant and toxic effect on the lungs, and that happens in different ways through inflammation locally in the lung, oxidative injury, which is kind of the result of these reactive oxygen species, and then by immune system activation in general, which of course leads to local inflammation, but there's more and more about systemic immune system activation and inflammation that leads to lots of health consequences chronically. And in the longer term, people actually have changes to their genes. Which can lead to disease. And here on the right side, this little figure, it just shows some of the things that are found in cigarettes and where you'd otherwise find these things. And of course, looking at these things, you wouldn't want to ingest these things into your body in any way. Next slide, please. Let me talk a little bit more about actually e-cigarettes I wanted to mention. So this figure on the right side kind of takes you through the history of e-cigarettes and now these pod-based vape pens. And so they've been around since 2007. And now newer versions of them can contain even higher concentrations of nicotine. And so nicotine toxicity has really been on the rise since 2009, attributed to these devices. They contain a mouthpiece, a liquid, a battery, and then an atomizer or a heating element. So they're pretty simple.
In healthcare. So
They've been even attributed to something called EVALI, which is an e-cigarette associated lung injury. People presented with respiratory failure, and so they have an inflammatory process in the lungs that led to sometimes severe respiratory failure, people being in the intensive care unit and on mechanical ventilators. And ultimately, and that was in the news, of course, a while back. This was pre-COVID. And it was ultimately attributed to this additive vitamin E acetate in e-cigarettes in some of the liquids. But the point here is that the health effects remain largely unknown. Actually, there's some studies that show reductions in lung function for people who use these products regularly, and some data showing increased risk of respiratory disease already, even though they've only been out for about 15 years or so. And so there'll be a lot more on this in the near future as they've been around for longer. But the early data suggests that they are not without their risks and risk of respiratory disease. Okay, next slide, please. And so continuing on this theme, why is tobacco use bad? Carcinogenesis, so cancer-causing compounds. And so some of these are polyaromatic hydrocarbons, nitrosamines, and nicotine derivatives that are easily absorbed into the blood and therefore get transported around the body. Of course, the respiratory tract receives the greatest exposure. And this information has been known for a long time, such that they've tried to modify cigarettes over time. And so tar levels have actually decreased about threefold since the 1950s. But despite that, there's been little to no change in the incidence of lung cancer. And again, it's because of these carcinogenic compounds that are just easily transported across the body. Next slide, please. Thanks. And so smoking is the single largest population attributable risk factor for cancer death. And I gave you this number 27.4% already. It might be a little lower than that, but there's a range. But about a quarter of people, it's attributable to smoking. And because of those carcinogenic compounds and where they end up concentrated, the oral cavity, larynx, voice box, and lung cancer tend to be the most common sites for these smoking-related cancers, followed by the esophagus and urinary bladder, and esophageal in particular is more common in men. Next slide, please. And this is depicted in this interesting study from a few years back, and it was specifically looking at cancer deaths attributable to cigarette smoking in adults. And men are on the left side of this figure and women on the right side. And lung cancer is at the top of the list and really has the highest proportion of cigarette related deaths attributed to it. Uh, and then you could see for men, esophageal cancer is next, and it's probably about half or so. For women, it's actually pancreatic cancer, and it's a low percentage of that. But lung cancer is the big one, of course. And we can go to the next slide, please. And so lung cancer is the most common cancer and the leading cause of cancer death globally in 2018. Many of you might know that in the United States, lung cancer for men and women is the second most common cause, and this is excluding skin cancers. And so it's the second most common in the US, but the number one cancer killer. So breast and prostate are the number one cancers in women and men respectively, but lung cancer, number two, and the number one killer. And so how does Washington State do here? Again, this data comes from the American Lung Association, this figure here, and it shows the incidence rate per 100,000 people. And Washington is in orange and is in the average tier, so about 52 per 100,000 people. It ranks 13th in the country, close to above average, but still considered average by the American Lung Association. And this picture here is just a cut from a CAT scan of a patient who has emphysema, but also this lung cancer, which can be seen on in the right lung there, which is the left one, the left side of the picture, actually. Thanks, and we can go to the next slide. And so I do want to mention COPD as well. It's simply put as a progressive and chronic lung disease that makes it difficult for people to breathe. And there's a spectrum of this disease, but it ultimately leads to airway and lung damage and ultimately respiratory failure resulting in death. It's currently the sixth leading cause of death in the United States, but it's expected to rise on that list. And really, we can manage symptoms of this to a degree and to a large degree in some people, but there's no cure again. So it's a progressive disease, and it's estimated that about 5% of people in the state are affected by this. Next slide, please. And so this kind of leads me back a little bit to the earlier slide where we talked about preterm delivery and low birth weights as well. And this is a simplified slide, but what I wanted to show is that lung function, and this parameter on the y-axis here is FEV1, it's a measure of lung function, and then age on the x-axis. And so lung function actually increases until we're in our 20s or so, and then kind of plateaus. And then when we're 40 or so, no matter what, our lung function decreases over the course of life. And so that purple line is a normal person. And in smokers, they generally have an accelerated decline in lung function and go on to develop respiratory disease, again, commonly COPD. Now, what can happen to folks who are born prematurely or low birth weight, they tend to have underdeveloped lungs. And so that's that red line there where they don't have lung function that other normal people might have. And they may have a slow decline like normal people do, but they're going to be at a lower lung function and therefore more likely to develop COPD. Or they might have an accelerated decline for other reasons, or if they're a smoker and will develop probably early lung disease. And so that's how some of the effects of smoking on infants can manifest itself later in life as well. And we can go to the next slide, please. And I'm almost done here. And so as far as the cost of it, so this is the actual literal cost of a pack of average smoking rate was, here's the top 10 states as far as taxes and then average retail price. And Washington's high up there, number 9 on this list. So New York's the highest at $10.45 a pack, but the average retail price from fairly recently was just over $8 in Washington state. So quite a financial burden if you're, especially folks generally smoke. The ones that I tend to see in practice have a long history of smoking a pack per day or more. And we can go to the next in 2022. And what about the cost to Washington state? And these are annual estimated costs, $2.8 billion in state healthcare costs, and about $2.2 billion lost by employers from lost productivity from this. It's about $720 estimated per household in taxes. And this it was an interesting study from a COPD journal a few years back that looked at medical costs to employers for workers that have COPD, and you could see the costs are essentially doubled. So they divide it into medical and pharmacy costs, and then total is on the left side, and you can see that it's about $12,000 per year in COPD, and it's about half that for non-COPD workers. So it's substantial insurance cost as well. And I think the next slide will be my last one. Oh, sorry, just kidding, two more. And so kind of in summary, well, where does Washington stand? And the American Lung Association again puts out these grades for various aspects related to this. And so for smoke-free air, Washington State has great laws there and gets an A grade. Tobacco taxes, it's on the higher side and has a C grade. Access to cessation services is actually an F, and flavored tobacco products are readily available. And so Washington State has an F grade by the American Lung Association. And then the one all the way on the left is tobacco prevention and cessation funding, which you can see is an F grade. And this comes down to the money, and that's on the next slide. And so this kind of depicts smoking was 15, and so there's a red bar. State funding on the top line for tobacco control programs was about $6.5 million, and with an additional just under $2 million for federal funding. So the total funding for state tobacco control programs was about $8.5 million, where you can see the CDC best practices is substantially above that. So the percentage of the recommended level is quite low there, 13.2%. And then you can see all this compared to the tobacco-related revenue that the state brings in, and so most of that money is obviously going elsewhere. Just over $500 million the state brings in, and I think that's my last slide.
Well, that was amazing, and I have questions already, but I'll have to save them until the end. Thank you so much. Very quickly, this is a little bit repetitive, but impact on employers and health plans of smoking. Dr. Decato mentioned lost productivity. This is nationally about $365 billion per year from smoking-related illnesses. So that's something to think about if the hat you're wearing is that of the employer or the purchaser of care. Smoking breaks productivity loss is the single largest cost that private employers incur from a smoking employee. And absenteeism, I think most people understand, is higher in smokers and former smokers, probably due to the illnesses that they incur and more seriously. It does stand to reason that insurance costs are increased for all of us because of this, because we need to cover all of the smoking and secondhand smoke related illnesses. And that is the concept of insurance. Even those of us that do not smoke are paying more for healthcare due to other folks that are using tobacco. And then this came from a little bit of research I did on insurance costs related to smoking. So under the Affordable Care Act, it is allowed that smokers may be asked to pay up to 50% more than non-smokers for their premiums. It just says the Affordable Care Act allows 4 factors to increase their premiums: age, family size, location, tobacco use. And it kind of depends on where you live or work and what types of plans that you have. If you buy on your own, then insurance companies, so for those plans that are sold on the exchanges, whether they be the federal exchange or state,
We started to plateau, and now
higher premium. My comment on that, and it was in the research also, is that there's an equity impact to higher premiums. So charging a person 50% more for their premium may reduce their likelihood of accessing healthcare at all. They may forego the insurance. They may choose a super high deductible plan that essentially means you forego your insurance and so forth. So we have to be careful about utilizing some of those levers. So we will move on to what we can do now that we know the various harms that are caused. We need to figure out a way to help people who want to stop smoking, or maybe sometimes they don't, but they probably should stop smoking. Talk about those cessation modalities. And our next expert is Brandon Almernick. He is the certified tobacco treatment specialist for living tobacco-free services at Fred Hutchinson Cancer Center. So very well qualified to talk with us about this. And the floor is now yours, Brandon.
Great, thank you. Can you hear me okay?
Yes.
Perfect. So I'll be briefly covering today some of the cessation modalities for tobacco use, their effectiveness, how they work, and I'll also provide implementation guidelines for tobacco use or tobacco cessation programming as well. So next slide, please. I apologize for the small text here, and I'll make sure that this is all available to you and answer any questions. But this is a brief description for the first line treatment medication options for tobacco cessation. On the left-hand side covers the nicotine replacement therapy medications that are commonly used, starting with the nicotine patches from 21 milligrams through the 14 and 7s and fast-acting nicotine replacement therapies, as well as first-line treatment prescription options, which is varenicline, or known by its brand name Chantix. We typically use varenicline now, as Chantix has been mostly over used with the generic version for varenicline, and then bupropion or Wellbutrin as well as a second line agent that's commonly used. And the less commonly used nicotine inhalers and nicotine nasal sprays, which primarily comes down to the cost of those. So next slide, please. And I'll let Sharon cover a little bit about the modalities covered in the WHA plan survey.
Right. So in just a bit, we'll talk about the results of that survey that I mentioned, but this is the list of modalities that were covered in that survey. So Brandon's going to speak probably about some that aren't on this list and what he does, but this is what we were asked to survey our folks on. So just types of different counseling. So 4 different ways to get counseling. Then we have over-the-counter medications, which were mentioned on the previous slide, the 3 prescription medications, and then we had a big category for other, and there were some write-in things. So that's just kind of technicality, but if you're thinking about the survey and it may not match what you hear, that's fine.
Great, thank you. So looking at how do the modalities work, one thing that we typically recommend when using prescription pharmacotherapies is using nicotine matching for nicotine replacement therapies. So listed on the right-hand side of the slide indicates matching, so the slow-acting nicotine patches as well as fast-acting nicotine lozenges or gum use. So these typically align with cigarette smoke use. One thing to note with smokeless tobaccos is that they're usually a more concentrated, higher levels of nicotine. If a person is going through 1 can of smokeless tobacco per day, you can consider that closer to 40 milligrams of nicotine per day, and that's where you'll typically see a higher amount. These recommendation guidelines come through the Duke and University of North Carolina's tobacco treatment programming recommendations. And then looking at the prescription options as well with varenicline and bupropion, I can cover some of the prescription guidelines for those. And one thing I wanted to highlight from these is that no pharmacological treatment is one size fits all. And so we always recommend implementing prescription pharmacotherapy options with behavioral counseling as well. One thing to note with tobacco use is the comorbidities of behavioral health associated health complications. And so by utilizing behavioral health counseling solutions, typically we can facilitate those greater behavior changes and health outcomes for people, as Dr. Decato covered. looking at some of those negative health consequences, we often say stopping tobacco use, it's never too late. And through harm reductions, through stroke reduction or cancer reducing, by stopping at any point in time, we're able to help our patients. So next slide, please. So the evidence base for modalities, the top portion of that covers those first line treatments of varenicline or patch plus immediate release nicotine. Those can be used in combination as well. There's ongoing research on that, but as of right now, a current 2023 systematic review looked at using combination nicotine replacement therapy with varenicline as having the highest reduction rate in tobacco use among patients. And there's some more on there too. The bottom ones, the nortriptyline, clonidine, those have ongoing research into their effectiveness and use. So we typically recommend using the other options available for patients on there. With the numbers needed to treat, varenicline listed at 11, and then the combination nicotine replacement therapy has about a 1 in 15 effectiveness rate of stopping tobacco use at the 6-month period. Thank you. Next slide, please. Looking at the cost of cessation modalities is one thing to note in here, and what we recommend is that providers provide prescriptions for pharmacotherapy to reduce the barriers of access to medications. Washington state quit lines will often work with referral recommendations for patients that they receive to check their insurance eligibility for these medications. But for providers, it can be especially helpful to provide that prescription to reduce the barrier to those. There's a link in here to more information through the Washington State Department of Health for the recommendations of what is or is not covered through Medicare, Medicaid coverage. But working with private insurers or employee insurers can help with patients to understand what options may work best for them. Next slide, please. So I'll briefly cover the implementation and practice of tobacco treatment. So at Fred Hutchinson Cancer Center, we use a 5 A's framework. So asking about tobacco use, assessing for tobacco use, and then advising. I want to stress the importance of that one. For any medical professionals, we view that appointment and opportunity as a teachable moment, and coming from a trusted healthcare professional, simply advising a patient to stop tobacco use can begin to have that conversation about the process of change and achieving tobacco cessation. And then assisting is the 4th A, assisting and connecting the patient with resources, counseling, medications, and then finally arranging follow-up. It's really important to, at the time of visit, to go through that assessment, identify readiness to change, and then acting on that. So that way there's no barriers or feeling that the patient has the full onus on them and that they have the support. But another easier way is to just use the ask, advise, refer model as well. And that's what the Duke University North Carolina program recommends and uses too. Next slide, please. And then at the Fred Hutchinson Cancer Center, we use a stepped care model approach, and we use this with only 2 practitioners. And so I just want to make sure and know that it's easily implemented across the board, and really one champion can go through and make these changes and help patients out. So our step 1 is using the electronic health records for identifying all current tobacco users. And at that point in time, we provide every patient who's identified as a tobacco user with self-help materials. And then from there, they receive a referral to their program if they wish, which allows them access. We provide no cost nicotine replacement therapy and counseling for all patients at Fred Hutchinson Cancer Center. So we'll work with them through behavioral
healing, things like that.
The nicotine replacement therapy medications and ongoing follow-up to confirm its use. And then we also work with prescribing providers to address any psychiatric or substance use comorbidities and access to the prescription pharmacotherapies. So, Next slide, please. Great. I think that covers it. So thank you. I'm happy to answer any questions.
Thank you so much, and I hope you will all be putting questions into the chat. This is really helpful. So how did I manage to get there? Okay. All right, I'm going to quickly go over the survey that we did. This was in 2022, and you saw the modalities that
report on the health
about. So we did have 8 health plans respond, and their coverage in our state is about 3.7 million people. So it's a pretty good sample size. We had all of the plans that participated at that time in Medicaid under the Apple Health program, and then some of the larger commercial insurers responded to the survey. So the first question we asked, and I'm not going to go through the whole thing, so it's fine. Are you aware of the Department of Health's quit line? And reminding them that it offers 5 counseling calls and 2 weeks of nicotine replacement therapy for free due to the CDC funding. And 86% of the respondents did say yes, which is good, but some of them still said they hadn't been aware of it. So that's seen as an opportunity to publicize that quit line as a valued resource. So this is kind of complicated because we asked them many options for your individually insured folks, small group, large group, self-insured, and then if it was a Medicaid insurer. Our tobacco cessation benefits, just like a blanket statement, included in the standard benefit package. And what we were looking for is yeses and nos, but then also kind of barriers that may be being put to patients, such as either having to pay some co-insurance, a co-pay, or maybe having the provider have to go through a pre-authorization process. And so you can see in general, yes, at no cost, the majority of respondents said that yes, they were provided, but then there were some that answered yes, but it's at no cost, but there is a pre-authorization requirement. So there's a bit of a barrier there. There's some opportunities for improvement. I'm just going to go over just kind of a summary, the big takeaways that we took from this. Prior authorization is commonly required for the NRT nasal spray and inhaler prescriptions, which you can correct me if I'm wrong, Brandon, but those are those kind of immediate access, therapies that you talked about for a dual nicotine replacement therapy, and also goes hand in hand with the varenicline as one of the more successful modalities, apparently. So we're putting some barriers up for people for things that could really be helpful. Again, varenicline had inconsistent coverage without copay or prior auth. So they're putting up barriers there. Some of the good news of health insurance plans, most of them were familiar with the quit line, but many wanted the quit line to be able to refer their own members to the tobacco cessation benefits currently offered through their health plan. So, hey, do you have, Cigna or whatever? Did you know that Cigna offers this or that, and wanted that kind of a connection? They really wanted it. But many were also interested in learning more about opportunities to participate, and I hope many of you are on the line today so that you can hear about that. So definitely there's some opportunities to close some gaps. And I have a couple more little observations that I found. What can you do on that big policy level? We already know that we have a reasonably high cigarette tax. Our air is pretty clean, yay us. But according to literature, increasing tobacco taxes, implementing comprehensive smoke-free laws, and improving cessation access are among the most effective tobacco control policies. They would reduce the demand for healthcare to combat smoking-related disease and death, and reduce the amount that we spend on that. And luckily, we have many of those here, but let's improve cessation access if we can. That's definitely an area we can work on. We created an issue brief here at the Washington Health Alliance. Was not widely circulated, but it will be following this webinar. We'll update it if we need to, and then send it around. We talked about employers and health plans can eliminate copays and co-insurance for smoking cessation, expand their benefit coverage to include counseling, over-the-counter, and prescription meds, utilize the Washington State Quit Line to refer their members tobacco cessation benefit information, promote the Quit Line with the number there, and support our cessation efforts. And in response to that, well, not necessarily in response to that, but right along with that, our Secretary of Health, Dr. Umer Shah, remarked that the work of the Department of Health is reducing the burden of tobacco, not only in our state, but across the nation, around the globe. So that issue brief will be coming out again soon. And we all know that coverage of these benefits can improve health by reducing morbidity, mortality. It can improve health equity across populations, reduce absenteeism and healthcare costs, and in that improve employer and plan bottom lines. Something in it for everybody. Now, Heidi, I'd like to welcome Heidi Glassman. She's been our partner in this. She is the Commercial Tobacco Prevention Manager with the Washington State Department of Health. Welcome, Heidi.
Hello, everyone. Happy Tuesday. I hope you can hear me. So I'm here to just talk about some of our work here at the Department of Health. I wanted to kick off with this concept of a three-legged stool. This is a pretty common concept in prevention and some other fields, but that to create these optimal tobacco cessation outcomes, you really need multiple tools to do that. And for tobacco cessation, that includes increasing and improving access to treatment, ongoing provider education about cessation, and then increasing public awareness of treatment options. If you don't have one of these legs or anything, sometimes the efforts or the optimal outcomes kind of weaken. And a key outcome kind of not mentioned, I'll joke that it's the fourth leg that you can't see behind this three-legged stool, is having that comprehensive statewide tobacco program to make sure these efforts are being coordinated and ongoing.
Constituents that have been.
Please. So what I wanted to do is just quick go over our current strategic plan and what it focuses on for cessation. So within our strategic plan that runs through 2025, we have goal number 3, which focuses on leveraging resources for promoting and supporting tobacco dependence treatment. And we have 3 different strategies, and I'll go over some examples of the work that's being done for each strategy. Next slide, please. So strategy number 1 is increase access to resources. So this is how can we expand the resources that are available? How can we continue to improve resources? And how can we streamline them? And then also how can we work on the insurance coverage, which is kind of, it's tied to the survey we did this last year. So next slide. And so specifically, I want to focus on improving private and public insurance coverage for best and promising practices. So some examples that I know Sharon shared up earlier is really focusing on that removal of pre-authorizations and then having that no cost for the following treatments to really ensure that they have access to that care and it's as barrier-free as possible for them to do it. Next slide, please. And so the next strategy kind of looks at how do we build that healthcare knowledge so providers feel comfortable talking about tobacco and nicotine addiction, and how do we support that? So some of the strategies we discussed here, kind of the strategy we discussed really looks at how do we build tools and how do we link and connect providers or kind of non-traditional providers, we call them, in school facilities, et cetera. And then how do we also engage behavioral health, as that is a huge part related to tobacco use. Next slide, please. And within that, kind of some things that we are doing at the Department of Health is we are developing and expanding a number of toolkits and webinars to support provider education, especially those that maybe also serve patients that have substance use disorder. And then we also look at making sure that there's CMEs related to that to incentivize providers to attend. Like I said, including those non-traditional partners, and then also focusing on those cultural competencies and health disparities that exist. And then we are also focusing on health systems change to really integrate tobacco cessation treatment into care, really leveraging those partnerships with local health systems, supporting tobacco treatment specialist certification for providers, and offering ongoing technical assistance and support. And some of these images here are different partners that we have that we do this work with. Some of them are at the national level with some of our voluntary organization partners. And then specifically, I want to call out the University of California, San Francisco Smoking Cessation Leadership Center. We serve as one of the tobacco-free leadership academies for tobacco-free recovery. And they have been a huge support in working in our healthcare systems change. Next slide. And then the last strategy is really working on providing actual services to underserved populations. So this is specifically focusing on our quit line, offering what's called our Tomorrow Health Cessation app, and then also focusing on youth dependence treatment services where we can and where we are able related to vapor product use. Next slide, please.
Where you'd otherwise find.
I'm going to touch on, so we have our Washington State Quit Line. So right now, our Quit Line has what's called 5 conversation programs. And so you can so you get 5 calls for the specific program. And then for priority populations, you can get up to 7 calls. And right now, those are for those who are pregnant and those with behavioral health conditions. We do provide nicotine replacement therapy for 2 weeks. Or up to 4 for those for behavioral health conditions. And then our conversations can be done in a myriad of modalities, which is really exciting for us. Many probably know historically, you call the 1-800-QUIT NOW number. Now you can actually talk with your coach or your quit coach via text message, online platform, or phone call, which really expands those opportunities. And there's also an option for individual and a group messaging if you prefer kind of that peer support environment. The Quit Line is also where we have our youth-focused texting line as well. Next slide. And then we also have what's called our Tomorrow Health app. So this is a free app you can download on your phone. We have 2 different ones, one that focuses on smoking and tobacco, and then one that's specifically vapor products. The smoking and tobacco app is best for those 18 and older. The vapor products app is available for anyone 13 and older. It provides ongoing support and education to help individuals on their cessation journey using the acceptance and commitment therapy or ACT. And so it has a myriad of lessons and conversations and activities you can participate. And for those 18 and older, you can also obtain 2 weeks of a nicotine replacement therapy for free. And that is what I have to share at the Department of Health. I think the next slide is just a thank you slide. Happy to answer.
There's a lot going on. Yes, so Nick or Adria, if you've been monitoring the chat, just speak up if there's some questions. Looks like there probably are. And while you're looking there, I wondered to Dr. Decato, when you were talking about the deaths that are associated with smoking related illnesses and so forth, is there an equity aspect to that? I mean, are certain populations more susceptible to the cancers or COPD or anything about that?
Yes, thanks for the question. And I meant to mention this a little when we were talking about lung cancer and COPD specifically, but there are definitely health disparities that exist for those conditions in and of themselves as well. And so just in the diagnosis, for example, of COPD, and probably the best example is Black persons tend to be diagnosed later and less severely, as an example. So there is that aspect, not only related to smoking and maybe exposure to secondhand smoke, but in these medical conditions that ultimately are the result of smoking too.
So let's see, I see Dr. Harris has a question that just came in, so I'm just gonna go ahead. It said, for Brandon, do you have recommendations regarding combination cessation treatment with varenicline and NRT?
Yeah, so at Fred Hutchinson, with using combination nicotine replacement therapy with varenicline use, we have really low barriers to using that because varenicline serves to block the nicotinic receptors. It does a good job of really reducing cravings and reducing the effects of nicotine itself. So it removes a lot of the pleasurable aspects of tobacco use, assisting with that behavioral component. So for a lot of people, when using combination nicotine replacement therapy with the patches on and using varenicline, they're really not getting a lot of the nicotine through that, but it's more the behavioral support of knowing I have that patch on, I'm supported through nicotine, sustained release, and I can use gum and lozenges.
Care unit and on mechanical ventilation.
Actually like to recommend is the lozenges are a really great approach. The gum does require some education around proper use, having to, you pretty much chew it a couple times, park it in a cheek under your gums to get that use. And within 30 minutes, for a lot of patients, it's sort of a barrier, whether it's jaw soreness or having implants or dental work that needs to be done. So the lozenges are a really underutilized but great option to use in combination with those. And then yeah, varenicline really working kind of to cover the behavioral or the psychological aspects of that.
I have another question here for Dr. Decato. It says, so the information that had 2017, 2018, 2015 for commercial tobacco and health disparities slide, is that the most recent available information?
The most recent that I could find, yes, for specific to Washington State, and that data was 2015 actually. And so if you look from Washington State in 2015, the smoking rate was 15% to what the American Lung Association is reporting in 2022 is 12%. So there's a little bit of a decrease there over time, certainly.
We do
Sorry for
have,
confusion there.
we also have a state representative, Paul Harris, who is going to sponsor legislation to get rid of prior auth in session 2024. We wish you lots of good luck on that one. How can we help with that? Slide presentation, yes, that will be distributed to everyone who registered. Are there any other questions? See, Heidi answered something. I guess, well, we're almost done. I had another quick question. This one's for Heidi. So you talked about the community-based organizations are partnering with other people, but I kind of wondered, is there a specific example of like an equity-related CBO effort just here in Washington State that you're trying with the Department of Health? Either to the Native American community or any examples?
Yeah, so one specific example we have is with our Black American African-born communities. They have higher or disproportionately higher use rates of menthol commercial tobacco products. And so we are working on developing a cessation toolkit specific for those populations that we hope once that's developed, it's currently being developed in partnership with the Center of Multicultural Health, which is a community-based organization based in Seattle. They also serve as our priority population contractor for Washington State for tobacco and cannabis. So we are hoping that we will develop that initial toolkit and expand on it to different populations that experience disproportionately higher use rates for menthol tobacco. And it's an opportunity to, they're going to develop the toolkit and then hopefully go out and train different providers throughout the state and non-traditional providers like community health workers, et cetera, so they feel comfortable having that kickoff conversation regarding tobacco cessation in those populations.
Excellent. Good example. We have asked about when the recording of the webinar will be available. I have to defer to my team here who will be reviewing it and making sure we, have a good recording without me going and stuff like that in there. So a couple weeks, I would guess, but we'll go as quickly as we can. You're all responding to your own questions, which is great. We have some good thank yous. So I want to, again, if anyone has questions about this, you can contact me directly. We should have our email somewhere. If you just got Nick Rondino's, which is great, from the invitation, or Adria Moskowitz, we will coordinate here at the Alliance and get you to the right folks. I really want to thank our subject matter experts, Dr. Thomas Decato, Brandon Amernick, and Heidi Glassman, and of course, multiple thanks to Heidi and the team at the Department of Health who invited us to partner in this initiative. Thank you so much for the wonderful work, and that will conclude our conversation today.